Okay. So the first speaker is Professor Mohamed from Egypt, and the topic of his is the endometrium as a cause of implantation failure. So as you know, he is a distinguished physician and scientist. So now, floor is yours.
Good afternoon, everybody. I would like to thank Professor Suru and the organizing committee for their kind invitation. My talk today is about the endometrium as a cause of repeated implantation failure. What is the real place of a problem in the endometrium in patients who fail to become pregnant? I'm going to discuss the background of repeated implantation failure. What are the possible endometrial factors to cause failure of implantation, the magnitude of the role of the endometrium, and finally, is there any possible treatment for repeated implantation failure? Well, the first question is, does repeated implantation failure really exist? There is a big doubt that there is something called repeated implantation failure. Now in the literature, it is quite common that patients will fail more than 2 times, will fail to become pregnant after 3 times without any problem in the endometrium, without any problem in anything, simply because IVF does not work every time. And to be repeated 3 times is something which can happen, and it doesn't mean we have really a problem. There is no clear definition, no clearly identified impaired function. This is the Lugano repeated implantation failure workshop, which was a special meeting in the Italian part of Switzerland, just to discuss and to find out, is there something called repeated implantation failure? And if it really exists, how big is the problem? And what are the possible treatment for this condition? Several investigators do not believe that it really exists, and if it exists, it is only present in 1 to 5% of patients who fails more than twice of IVF. And one definition, failure to achieve pregnancy after transferring 3 good quality embryos in fresh or frozen cycle in young women below the age of 35, or 4 embryos for 4 trials in women above the age of 35. If they fail 3 or 4 times, then maybe you can call it by this definition, this is repeated implantation failure. So, what are the possible causes of this failure? Infection, chronic endometritis, or a problem in the endometrial thickness, the endometrium does not get thick enough, or what was called the endometrial receptivity and proved to be not existing, that the endometrium is not receptive, or in fact, in the presence of microbiome, bacteria at a very, very small level, or the presence of mechanical factors affecting the endometrium. Chronic endometritis and repeated implantation failure. The endometrium is a really unique tissue. This tissue, every month, is going to drop completely, and for infection to occur in this endometrium is not easy, because the endometrium is being shed every month. There is proliferative stage and then secretory stage, and the whole thing falls down. So, practically speaking, infection is not common, or is extremely rare. The endometrium contains large variety of immune incompetent competent cells, natural killer cells, macro players, T cells, neutrophil. It contains everything. But this doesn't mean that the endometrium have infection. And it is well accepted now that the presence of microorganisms in the uterine cavity does not equal the presence of inflammation. If you retrieve bacteria from the endometrial cavity, this doesn't mean there is infection. Exactly like if you retrieve lots of bacteria from your mouth, it does not mean that you have an infection or in your mouth. Chronic endometritis actually is very poorly investigated pathology, which has been related to repeated implantation failure. It was said that every woman who fails to become pregnant, they say, oh, this is chronic endometritis. Based on endometrial lining of patients who later went hysterectomy specimens were examined for infection in the endometrium. And for benign conditions, the presence of what was diagnosed as chronic endometritis was only in 10% of all these uteri, and only in 3% of women who has abnormal uterine bleeding. The only type of infection which is really recognizable are specific infections, like tuberculosis infection, bilharzia infection. These infections really exist in the endometrium, but now they are extremely rare, very, very rare and very uncommon, and they are usually secondary to tuberculous salpingitis, to the tube. The chronic endometritis diagnosed by hysteroscopy and endometrial biopsy showed marked variability. There are extreme variations in the hysteroscopic findings. From it could not be diagnosed, it could be suspected, this is true, this is chronic endometritis, and the endometrial biopsy to diagnose chronic endometritis, there must be localized inflammation of the mucosa, presence of edema, which is usually very common. The most important thing actually is the presence of extensive amount of plasma cells. This is the most important criteria, histological criteria for diagnosis of chronic endometritis. And conventional pathology shows the presence of plasma cells. The procedure is not standardized. There is no agreement between pathologists about the amount of the number, etc. So there are marked variation. So you have to resort to immunohistochemistry, which is much more complicated. So again, chronic endometritis does not have specific symptoms. There are no specific symptoms for this condition to suggest that this patient has chronic endometritis. So chronic endometritis is poorly understood inflammatory process, and actually its prevalence is very, very rare, and its effect on reproduction is not completely known. So this is the first possible cause for repeated implantation failure, which practically and actually is extremely rare or not existing at all, except in specific infections. Endometrial sickness and recurrent implantation failure. Some women, they have a thin endometrium. When you transfer the embryos, you will always find that the endometrium is very thin, and this could be a possible cause of implantation failure. So endometrial sickness is an important factor, and the general consensus, the best way is to evaluate it by vaginal ultrasound, and it's quite easy to measure the thickness of the endometrium. But there is no agreement actually about the thickness of the endometrium, which is necessary for implantation to occur. There are marked variation in the reports in the literature. In a large systematic review of 22 studies, any endometrial more than 7 millimeters is okay for implantation. But less than 7 millimeters, it could create a problem in this big study. In a large Canadian study with over 43,000 fresh and 50,000 frozen transfers, the live birth rate increased significantly with the increased thickness of the endometrium. The more the endometrium is thick, the more the implantation or the pregnancy rate, until you reach 12 millimeter of thickness. After 12 millimeter of thickness, the pregnancy rate will improve, not improve anymore. This is this big Canadian study. And the last year, very large Turkish study by Paris actually was a real shock in this topic. Particularly, I was reviewing this study for fertility and sterility before its publication. And this study, also a very large study, almost 1,000 patients, 1,000 embryo transfer. And they said that it doesn't make any difference, the thickness of the endometrium. 3, 4, 5 millimeters gave the same pregnancy rate as 10 and 12. And a very large study and unconventional and different from previous reports. So we should also consider not canceling transfers completely for patients who fails to have a thicker endometrium. The etiology of thin endometrium is not exactly known and is not always correctable. I mean, there is no specific way really to correct it. You can give more estrogen, extend the estrogen, but usually it doesn't work. Or finally, if it doesn't work, you better transfer the embryo in a natural cycle. Just on a natural cycle, on the time of ovulation, you transfer the embryo. Of course, there were some suggestions based on no evidence, like infusion of platelets-rich plasma, granulocyte, colony stimulation growth factor, Viagra. All these drugs and all these techniques completely useless, does not work and should not be tried. And anybody who wants to try any of this, it should be within the framework of a randomized study to prove something, but not for a patient undergoing any treatment. Endometrial microbiome, the exact role of the relationship between microbiomes and the female reproductive tract remains actually not established. We don't really know what is the amount of microbiomes in the genital tract. Numerous publications suggested and showed that the endometrial cavity is not sterile. The endometrial cavity, you can find bacteria without the presence of infection. And it was claimed that there are certain types of microbiomes can affect implantations, but this was never confirmed. It was only a suggestion. The majority of the studies did not find any significant association between endometrial microbiome and treatment of infertility. So antibiotic therapy or giving all these things is absolutely useless, and there is no proof that it does work. In view of the existing divergence of results and different methodological methods, if we want to study this, we should do further studies for the microbiome. What about the endometrial receptivity, which was a big thing and big conferences made for endometrial receptivity, and specific investigation was done, and lots of treatment and millions of dollars were spent by poor patients to treat the poor endometrial receptivity. Endometrial lining revealed over 300 genes that were different from the control group, and the ERA test, which the endometrial receptivity analysis, the Spanish group invented this test, which analyzed the expression of 200 genes to diagnose poor endometrial receptivity. ERA test before frozen embryo transfers. This is a systematic review and meta-analysis recently done, comparative studies of frozen embryo transfers of ERA before transfer versus no ERA. 8 studies, over 2,700 patients, no significant difference between ERA or no ERA on the ongoing pregnancy rate or the live birth rate. So the whole world met in hundreds of meetings, promotion by a pharmaceutical company owned by a Spanish IVF center, and millions of dollars were spent on that test, and poor patients in the third world use this test extensively very expensive test for absolutely no use. ERA test requires a biopsy in the cycle before transfer. The test will decide the time of transfer in the cycle. All good studies show that the test does not improve the outcome. Unfortunately, ERA test was marketed and promoted strongly before good randomized studies were done to prove its efficiency. Although some of the mechanisms of impaired endometrial receptivity are understood, but no treatment options are available. Now we come to the easy thing, which all of us know, which is anatomical problems. Fibroids, we all know that, and possibly polyps, intrauterine adhesions, and Mullerian anomalies. Fibroids, we know that subserous fibroid has no relation, and definitely submucous fibroid prevents implantation or at least reduce implantation, and it should be removed hysteroscopically. Intramural fibroids, there are no one randomized study in the literature to say, shall we remove intramural fibroids or not? But the general consensus from non-randomized studies that multiple fibroids or fibroids which are a bit close to the endometrial cavity could be removed. Not should, but could be removed. Intrauterine adhesions, it imposes functional layers of the endometrium and prevents implantation of the embryos, and of course, unless it is corrected, and usually it is, especially the severe forms, are not possible to correct it. You cannot do anything for these patients. Septate uterus, bicornate uterus, and other anomalies, generally they have a poorer IVF outcome. What about the uterine septum? First of all, there is only one randomized study in the whole literature on the excision of septum hysteroscopically versus no excision. And there are hundreds of thousands, probably millions of women who became pregnant on their own, delivered babies at term, and they have a uterine septum. So, and uterine septum is discovered accidentally in women with 6 children and 6 full-term deliveries as usual. So in this cohort study, this is not a randomized study, of 151 women who underwent septum resection and 106 women expectant treatment. They were followed up for 46 months, 4 years follow-up. Live birth was 53% if we resect the septum, the cumulative pregnancy rate over the 4 years, or 71% if you don't do anything of the patient. So this non-randomized study showed clearly that excision of the septum is of no value and is not indicated. And the only randomized study is by this Dutch group, the Rekin group. They only randomized 80 women in a multi-center international study with a proper intention to treat analysis. The live birth rate was 31% in septum resection and 35% if you don't do septum resection. So it is clear that septum resection is of no value, particularly if we know that many people who are not experienced hysteroscopists, they all go on and do septum resection and induce intrauterine synechia and serious problems which will prevent future pregnancy for these women. The majority of Lugano group who studied the repeated implantation failure agreed that the recurrent implantation failure is a rare condition, suggesting that the upper limit to be 4.5 IVF cycles to start thinking of repeated implantation failures. Data on repeated implantation failure have largely overvalued, overdiagnosed, over-treatment without sufficient critical assessment of its true nature. And in conclusion, ladies and gentlemen, recurrent implantation failure is not an overt clinical entity. Recurrent implantation failure has been overvaluated, overdiagnosed without sufficient evidence. If repeated implantation failure really exists, it occurs only in 1 to 5%. And thank you very much.